Good afternoon, everyone, and welcome to today's webinar, Demystifying Robotic Technologies, a review of current data and integration of pathology and imaging. Before we get started, I would like to go over a few items so you know how to participate in today's event. You will have the opportunity to submit text questions to today's presenters by typing your questions into the question pane of the control panel. You may send in your questions at any time during the presentation. We will collect these and address them during the Q&A session at the end of today's presentation. I would now like to introduce Dr. Janani Reisenauer. Dr. Reisenauer is the Thoracic Surgery and Interventional Pulmonary Medicine Vice Chair at the Mayo Clinic in Rochester, Minnesota. Welcome, Dr. Reisenauer.
Thank you so much, Eric, and thanks for everyone who is on the webinar today. This is an exciting program that we have today discussing demystifying robotic technologies. Along with me today, my co-panelists, who I'll briefly introduce, and they'll take a second to introduce themselves as well. On the call, we have Dr. Ganesh Krishna. He's from the University of California, San Francisco, and he's going to be talking about the data that currently exists and how that should be taken in the context of previous data in the world of interventional pulmonary and diagnosis of peripheral pulmonary nodules. Also, we have Dr. Sebastian Fernandez-Bussy, who's from Mayo Clinic in Jacksonville, Florida, and he's going to be discussing some of the discrepancies and what to expect with pathology as we evolve into a robotic bronchoscopy era. Finally, I'll be talking about the different imaging applications that exist that can be used in conjunction with this technology, and then hopefully we'll have some time for a few questions at the end. So without further delay, I'll hand it over to Dr. Krishna.
Good afternoon, everyone. My name is Ganesh Krishna, and I'm a professor of medicine and program director for the UCSF Palo Alto Medical Foundation Interventional Pulmonary Program at El Camino Hospital. And today I'm tasked with discussing the data that is available on the robotic technologies. The general topic that all three of us are going to address is demystifying robotic technologies, and what we mean by that is for us to come up with an argument to look at this system and other systems beyond a robotic technology and look at it as a peripheral navigation access platform. So I will get the disclosures out of the way. I do serve as a consultant to Intuitive Surgical, but there's no specific conflict to this particular talk. I also am a consultant to Boston Scientific. I use their forceps for the biopsies, and consultant for Olympus America as well. So we all know that circa 2002-2003, due to the inherent deficiencies of the conventional bronchoscopy as a tool to access the peripheral areas of the lung, there were image-guided procedures that were introduced to interventional pulmonologists, the main one being superdimension. However, we can sum up all the existing navigation platforms with certain common denominators. And one of the things that is important for us to understand is to compare and contrast different peripheral navigation platforms so we can understand and apply the data that is generated from each of these technologies to our individual practices. So current problems that we have today are how far can we reach? And we arbitrarily divide the lung into the inner third, middle third, and outer thirds without any specific anatomic demarcation, but it's kind of a visual estimate, but generally accepted as the inner, middle, and outer thirds with pulmonologists in terms of how we can access. And a lot of the factors depend on the size of the access tool, the airway that leads into it, and the proximity to structures that we really don't want to penetrate with a sharp tool. So location matters. We all know based on statistics that upper lobe nodules are more likely to be malignant than lower lobe ones. And specific anatomic locations can be sometimes challenging. For example, the left upper lobe apical-posterior segment, lesions that are close to the fissure, especially in the right side in the middle lobe between the major and minor fissures, is probably one access pathway that takes it to the target. Lesions that are close to the diaphragm can be problematic in terms of its movement with the respiration and the shape of the diaphragm and the lung, which is a conical structure. The way it expands and contracts can sometimes be challenging. Lesions close to the heart can be problematic with cardiac pulsations affecting the axis of the nodules that is of interest to us. Lesion size matters. Small nodules, as you know, have been challenging to access thus far, and big masses have their own problems with areas of necrosis and post-obstructive phenomenon. So depending on how we volume average those nodules can sometimes be problematic in terms of getting an appropriate tissue diagnosis and adequate sampling to obtain a complete diagnosis. Articulation can be an issue, and articulation, especially into the upper lobes with mediastinal distortion, which we will talk more about when we talk about CT to body divergence and airway to nodule relationship. Stability matters, and that's, I think, one common factor that the robotic platforms actually bring to the table. No matter how skilled an interventional pulmonologist is, it is difficult to stay in place for an extended period of time and maintain that position, and therefore stability matters a lot. We will touch a little bit more on CT to body divergence and nodule to airway relationship in the next slide. But there is an ongoing spirited debate and a lot of valuable learning in terms of whether or not we need endoluminal assessment in the periphery of the lung. Do we need continuous visualization of the peripheral airways as we do the biopsy, versus is image guidance sufficient to the biopsy and have a peripheral visualization until we get close to the target? Obviously, therapeutics is in everybody's mind, which would necessitate stability of the system, accuracy of access, and it would be premature to talk about therapeutics without establishing clear cut accuracy and stability of the system over an extended period of time, and calculating zone of ablation if we were to ablate tumors, and make sure that we are not ablating unwanted structures that can be a problem for the patient. A little bit more in detail on the CT to body divergence and the airway to nodule relationships. So the left-hand cartoon actually shows how CT to body divergence occurs. And as you can see, it's more pronounced in the bases due to the shape of the lung, which is a conical structure and not a perfect cone. And the change in thoracic volume due to the patient going from upright to supine, whether patient obtains a CT scan with an inspiratory hold, whether a neuromuscular blockade is used during anesthesia, whether PEEP is applied, and so on and so forth. All of those things can change the position of the nodule. And in any image-guided system which overlaps an image onto the patient's thorax, these factors play a big role. And studies have shown that the CT to body divergence is more pronounced in the bases than in the apices. On the right-hand panel, you can see the alteration of airway to nodule relationships. This matters more as we have increased interest in going after smaller and smaller nodules. And we know that when the nodule is greater than 8 millimeters, the likelihood of that being malignant kind of jumps up to about 12 to 15%. And therefore, accessing these nodules are of great interest with advanced technologies, with not the YESR generation peripheral navigation platforms, but the current generation navigation platforms. And how is ION different from the others is one of the topics that we will discuss today. And you can see in the panel that if there is thoracic volume distortion in the right-hand panel with the trachea being shifted to the contralateral side of the nodule, and also there is pressure effects on the mainstem bronchus as well as the upper lobe turn, which two factors play a role in making the nodule go away from the conduit airway. One is the distance of the nodule from the access airway and the size of the nodule. If we are going after smaller nodules, this distortion may actually change the airway to nodule relationship. In the bottom panel, there is a real-life example of a therapeutic bronchoscope distorting the mediastinum. And on the in the left side, where an ion catheter has traversed through the left mainstem bronchus into the left upper lobe, accessing a small nodule documented by cone beam CT without much distortion of the mediastinal structures. Now, this becomes important in systems that use electromagnetism, that uses sensing volume. So and some of the systems use a full thoracic volume with electromagnetism, and other systems such as Varan or Monarch uses a hemithoracic volume assessment. So it's important for us to know that distortion of the mediastinum that happens on one side of the thorax has an impact on the airway to nodule relationship on the other side, and therefore assessing a thoracic volume, whether it's a partial or hemithoracic volume versus complete thoracic volume as it happens in superdimension, can both be impactful. And the point being that electromagnetism-based systems and sensing volume-based systems have inherent deficiencies, and as we desire to access smaller and smaller nodules, the technology that is based on this platform may not deliver what we desire. And the other aspects of the existing peripheral navigation platforms is tip tracking. So we are not sensing the entire pathway from the trachea onto the airway branches all the way to the periphery. And we know that there are 17 to 25 generations of airways before we reach the respiratory bronchioles and alveolar sacs. So this level of distortion cannot be corrected in a system that only tracks the tip. So that is also an inherent deficiency of the existing platform. The other thing that is noteworthy is the airway reconstruction algorithm. So even for a system that tracks the entire pathway from the proximal to distal airways, if the airway reconstruction algorithm is not good, then the overlap will be insufficient. And most of the navigation platforms use the Vida diagnostic platform as the basis for the airway reconstruction algorithm, and that by itself has created some problems in terms of access to small nodules. So that said, what kind of data have we looked at, and what is the technological background that we can understand about this peripheral navigation platform, looking beyond the word robot, that makes it a desirable system, a competitive system in terms of accessing peripheral lung nodules. So the shape sensing technology has been widely discussed these days, and let's discuss what shape sensing technology actually means. So as I mentioned before, existing peripheral navigation platforms are looking at the tip and they track the tip, which by itself can be problematic due to the mediastinal distortion as we discussed before. This system actually tracks the entire pathway from the main trachea all the way to the periphery with laser bundles going alongside, and every single data point on the vision probe and the catheter is tracked at 6 different axes: X, Y, Z, roll, pitch, and yaw, and the feedback is given to the system. And the system constantly strives to maintain that position as we navigate, reach the periphery, and try to biopsy. So that constant effort in retaining that shape sensing technology will help us maintain our position and limit the distortion that can cause airway to nodule relationship changes in the periphery. And we also have tools to correct our any deviation in that, because the system gives us feedback about the driving force that the catheter has in the proximal and distal portion with a visual estimate of the driving force. So if we sense too much driving force, we know that we are causing some distortion in the periphery, and it allows us correction for it. So that level of shape sensing is needed to access peripheral nodules, especially in the outer third of the lung, as we traverse through small airways. And we talked about airway reconstruction algorithm. So the airway reconstruction algorithm in this system is also a novel technology whereby the engineers have painstakingly drawn peripheral airways all the way from the center to the periphery in about 250 patients, CT scans, and then subsequent learning is based on artificial intelligence and machine learning, with the initial 250 scans being the ground truth. So that with more and more input from further iterations of the software will enhance this reconstructive algorithm, and there's much more room for improvement. So this is a very interesting technology that actually has revolutionized the airway reconstruction algorithm. And as I said earlier, even if you have a shape sensing technology, if you don't have a appropriately reconstructed airway, then you're not sensing the right shape. So it is a good complementary tool to the existing shape sensing technology to ensure accurate navigation and reach of targets. So the system does not use electromagnetism. As I said earlier, electromagnetism-based systems with sensing volume are largely becoming obsolete. So that, again, would be an additional advantage over and above what a robot can offer. And the airway tree lesion is sensed based on the voxel density that we do in the planning software, which is then superimposed onto the reconstructed airway, and that's how it tracks the target that we had previously marked to navigate and biopsy. So the catheter and vision probe with an outer diameter of 3.5 millimeters, this has two advantages. One is, as we know, the definition of a small airway is about 3 millimeters or smaller. Obviously, the airways are distensible, so we could use the distancing or the distension capabilities of the airway to navigate further. However, the 3.5 millimeter OD in the proximal airway cause less distortion in the mediastinum and less likely to cause airway to nodule relationship changes in comparison with the competitive system, which uses a mother-daughter concept, and the proximal airway, the proximal catheter is about 6 millimeters in outer diameter. As we go to the periphery, it's 4.5. So that mediastinal distortion combined with hemithoracic volume assessment with an ipsilateral field generator can be problematic in accuracy of the system. So this system uses image guidance in biopsy. We can discuss that in detail about, do we really need image-guided biopsy? Based on personal experience, and we've done about 150 cases of ion procedures now, there's not that many patients that have endoluminal component of these lesions, and others can chime in as to what their experience is, but my experience, there's not that many patients that have an endoluminal component. And combined with the fact that if you distend an airway, especially small airway in the outer third of the lung, you're basically blocking air from getting into it, and you're going to have the airway collapse in front of you. So all you're going to be seeing is a mucous membrane in most cases, especially in the outer third of the lung. So I don't know if that visualization can be very effective if your airway tends to collapse in front of you because you're blocking air entry into the lesion. And thirdly, a drop of blood is all that takes to obscure your view in the peripheral airway. So we have to be cognizant of that as well. So we jump into the data. We talk about the feasibility study. This was a prospective study on 29 patients with a mean nodule size less than 2 centimeters. And about 40% of the patients did not have bronchus sign, and they were able to reach about 97% of the patients and reported a diagnostic yield of 79%. This device that was used by Dr. Fielding and colleagues was a little bit different from the current system, both in terms of software as well as airway reconstruction algorithm. Now, going on to the study that we published, it was a prospective study, and it was not industry-sponsored. We looked at our first 52 patients with 59 nodules because we biopsied multiple nodules in the same patient, in some patients. And we enrolled patients consecutively for those who were referred for peripheral lung biopsies. So there was no selection bias. We looked at the overall diagnostic accuracy that we reported to be 86%, and sensitivity for diagnosis of malignancy that we reported as 84%. We also looked at navigation success, the number of cone beam CT spins, as we used cone beam CT as our secondary confirmation tool, and need for catheter adjustment after we navigate to the lesion, and also radiation exposure, biopsy tools, and procedure time. So these are the patient characteristics. The patients were in their mean age was in the 7th decade, and the distribution based on race and ethnic groups were in line with the population that we serve. And smokers and non-smokers were equal in distribution, with some current smokers. And patients with prior history of malignancies were included. And we also included patients with prior lobectomy or wedge resection. And one of the patients had an upper lobe resection, the other patient had a lower lobe resection, and the other third patient had a contralateral wedge resection. So our mean axial diameter was less than 2 centimeters, so 19.6. So the mean and median were less than 2, indicating a symmetric distribution of these nodules. A considerable proportion of our patients, about 30%, were either mixed or pure ground glass lesions. So all regions of the lungs were represented in the nodule location, and equal distribution, a little more in the negative bronchus sign was seen in our patient population. So we needed to make catheter adjustment in about 15% of the patients in 9. And what I mean by that is that we reached 100% of our targets. The only time we had to adjust is a directional adjustment. We did not have to re-navigate to a different airway. So minor directional changes was all that we had to do. And interestingly, all those adjustments were done in the upper lobe, raising the question as to maybe we did not have much seat to body divergence, but more of an airway to nodule relationship problem. I would like to point out in this time that we did use a standard anesthesia criteria with a 10 of PEEP, 8 ml per kilo ideal body weight tidal volume, and complete neuromuscular blockade. We used a 21-gauge needle as our first biopsy tool in all of our patients, and about 3/4 of our patients, especially those with ground glass lesions, we used forceps biopsies. And radiation exposure was comparable to a low-dose CT, and about 1/4 of radiation exposure due to cone beam CT compared to transthoracic needle aspiration. At least one study that included 1,100 patients, the radiation exposure was about 1/4. The study duration was about an hour, and did not have a extra time or too much of an extra time when we added a nodule to it, about 20 minutes. These are the biopsy results. And the two things that I would mention in this, when we mention atypical cells as diagnostic, we only included those patients where the pathologist reported as atypical cells favor malignancy. If the pathologist reported atypical cells favor reactive, we consider that non-diagnostic. And both those patients that they reported atypical cells favor malignancy went to surgery and confirmed to have adenocarcinoma. And the inflammation, we had to see inflammatory cells in the lesion. We consider them diagnostic only if they completely disappeared in follow-up imaging. And when you look at the distribution of the lesion based on size, in the column or the row, the distribution seemed to be fairly uniform. The size did not indicate one diagnosis or the other. A follow-up on inconclusive nodules, we had follow-up time from 5 to 16 months. We did not consider them diagnostic even if the nodule completely disappeared, but if they had normal lung elements in them. So interestingly, that all the non-small cell carcinomas that we diagnosed, about 84% of them were stage 1 and 2. Our study did not look at this as an endpoint, and the numbers are small, so we cannot make any emphatic statement that we did make early diagnosis. However, it's worth noting that 84% of our non-small cell cancers were early surgical stage. And we also would like to point out that all the we did staging with endobronchial ultrasound, and none of those patients who went to surgery had further upstaging after we staged them with endobronchial ultrasound. These are the study characteristics for anyone to assess. When we look at a study, we look at the validity, the applicability, the reproducibility, and generalizability of the data. We did a prospective study. It was non-industry sponsored. We had twice the number of patients in the feasibility study, the same number as in the primary EMN study, and the nodule size were less than 2 centimeters. We did not have any age or size limitations. We used ground glass lesions, prior surgery, history of prior cancers, and we also biopsied bilateral lesions and did not have any tool restrictions. So we feel it is applicable to any kind of practice. Reproducibility, we are now looking at over 100 patients with the similar characteristics being analyzed with the intention to publish. And other studies There are non-published studies, including that of Dr. Pritchett, who has done probably the most number of cases now, as well as Dr. Volker, who also trains fellows, are at par with or are better than our diagnostic yield. So we are a community practice with an academic hybrid setting. We have a fellowship training, and we did not have any run-in cases. So this is basically applicable to any setting, in our opinion. So these are the comparative data to. I have 2 more slides and I'm done. So we can compare the 2 robotic systems. So I would argue that the Monarch system is not really a comparable system to Ion. They are 2 different systems. They have their own merits. Except for the robot part, which offers the stability. I believe the Monarch system is an electromagnetism-based system with the ipsilateral field generator and sensing hemithoracic volume assessment. These are the comparative data between the 2 studies. The Monarch study was a multi-center, ours was a single center, 54 versus 59 nodules, comparable. Our mean nodule size was about 4 millimeters smaller, and we had more patients without the bronchosign. And we did biopsy bilateral multiple lesions and also ground glass lesions. We reached 100% of the lesions. We used cone beam CT as secondary confirmation device, and the Monarch system used the radial probe EBUS. The comparability in terms of our minor adjustments in the nodule direction, I would compare that to an eccentric placement of the radial probe catheter. So that also argues in favor in terms of accuracy of the system. We only had 15% that that needed minor adjustments, whereas the eccentric location of the radial probe EBUS was about 41%. And there is the diagnostic yield. And in the Monarch study, they had a ability to cross over to a different procedure and got a biopsy from a different procedure in the same study. We did not have any crossover procedure time. Procedures that the user can use to access the nodules. So these are the discussions for future. Do we use standard anesthesia protocols? Is there going to be geographic variation? Should this anesthesia protocol be based on BMI of a patient? Should we do a randomized controlled study with standard anesthesia criteria? Did we actually make early stage diagnosis that needs to be further validated and looked at with larger numbers and other studies? What else can we do to decrease CT to body divergence and airway to nodule relationship changes other than adjusting for the driving force and using standard anesthesia criteria? Is CBCT emerging as the standard secondary confirmation tool? And what are the implications of that? And do we really need to have an endoluminal assessment at all times? Those are some of the questions that our study has raised, and more lively discussion and collaborations to prove or disprove these questions will be highly desirable to further enhance the system and therefore patient care. Thank you.
Thanks so much. I'm going to turn it over to Dr. Bussy now, who's going to talk a little bit about the pathologic implications of this technology.
Thank you, Dr. Reisenauer, and thank you for putting this webinar together and coordinating it. Thank you, Intuitive and ATS as well. I'm not seeing my slides yet. Okay, here we go. So I'm going to discuss the pathology, the different pathology implications of discrepancies of this technology. I would like to discuss that really the diagnosis yield of a navigation platform, any navigation platform, it has a very close relationship with the pathologist. That's very important because the navigation platform, in this case, a robotic bronchoscopy, would allow us to reach to the lesion, to reach to the nodule and put our tool in the nodule. But then it comes the pathology component to try to get a higher diagnostic yield. So I think that I would like to discuss two main concepts. One is are we able to put our tool in the lesion with the help of the navigation platform, in this case robotic, which we can talk about this as accuracy. And the other concept is really the lesion inside our tool, which will give us the final diagnosis, the diagnosis yield. So I would like to show you several cases to hopefully can help us understand this concept. This patient had a right upper lobe nodule. As you can see, we did robotic assisted bronchoscopy, and we got the diagnosis of adenocarcinoma. So in this case, was our needle, a robotic assisted needle in the lesion? Of course it was. So we had a high accuracy and a high diagnostic yield. Now, in this other case, that left upper lobe nodule, we also try a robotic assisted biopsy first, and the pathology result was atypical reactive epithelial cells. So we had to, next step, we did a CT guided needle biopsy, and the result was small cell lung cancer. So was our robotic assisted needle in the lesion? Probably not. So low accuracy, and our robotic was non-diagnostic in this case. Now, this patient had not robotic biopsy, but CT-guided biopsy. CT-guided biopsy of that right upper lobe lesion, and the pathology was non-diagnostic. They just saw fragments of lung tissue. So patient went wedge resection and had necrotizing granulomas. So was the CT-guided needle in the lesion? Probably not. So that procedure had a low accuracy. The CT-guided needle was non-diagnostic. Next case, as you can see, that right upper lobe lesion, we did a robotic assisted biopsy, and the result was suspicious for non-small cell lung cancer. So patient underwent wedge resection, and actually the final path was necrotizing granulomas. So was our robotic assisted needle in the lesion? Yes, probably yes. So was this a high accuracy? But anyhow, was non-diagnostic. So was this a pathology miss? Because as you can see, the wedge, the surgical resection, the final path was actually necrotizing granulomas and not malignancy. Next case, this one is CT-guided biopsy. Okay, so they did a CT-guided of that. It's hard to see there, but it was there's a very small left upper lobe nodule. Pathology showed atypical epithelial cells, but suspicious for non-small cell lung cancer. Patient did not want to do anything and was lost to follow-up. They came back just 1 year later, and actually CT scan showed that the nodule resolved completely. This is CT-guided biopsy. So was the needle in the lesion? Well, yes, we did get suspicious for non-small cell lung cancer, but it was non-diagnostic, and the lesion resolved completely in a follow-up CT scan. So was this also a pathology miss? The next case, this one is robotic. Right upper lobe nodule. It showed multinucleated giant cells. Now, patient underwent wedge resection, and it was squamous cell carcinoma. So was our needle in the lesion? Yes, it was, but this patient, that robotic procedure had a low diagnostic yield. Because actually the final path was squamous cell carcinoma, not multinucleated giant cells, not granulomas. So again, the concept of thinking is our needle in the nodule as accuracy, and that can depend, of course, is our navigation platform, our robotic platform, able to get us into the lesion and get our tool into the lesion. And that, of course, as Dr. Krishna mentioned before, depends on the size and location of the nodule, and also, of course, of the planning, different navigation factors, airway anatomy, and of course, as Dr. Krishna also mentioned, the confirmation with radial EBUS or using cone beam CT or SIOS-PIN. So all that can help us and do interfere in us being able to put our tool into the lesion, to reach the lesion and put our tool into the lesion. Now, diagnostic yield, again, is the nodule inside our, is the lesion inside our tool. So do we have the samples that we need to make a diagnosis? So that, of course, can depend on the intrinsic characteristic of the nodule. If the nodule has a lot of necrosis, then that's a problem. And if we're not able to identify where the necrosis is, if there's just in one part of the lesion, not in the other one, and we put our tools in just the necrotic part, so that plays a role. The different tools that we can use to do a biopsy, that also has a role. The pathology limitation of evaluating small samples, that definitely plays a role as well. And this goes along to any limitation to for any minimally invasive technique. I have shown you examples of robotic assisted bronchoscopy non-diagnostic and of CT-guided needle biopsies that also were non-diagnostic. So this is also a limitation of any minimally invasive technique. Now, to increase the diagnostic yield, of course, we can give more samples to the pathology, for example, that can definitely help. We can, instead of giving every sample to the cytopathology or cytotechnician that is there in the room doing rows, we can give to that person some of the samples and then put the rest in formalin. So that can help. We can use more forceps, again, for the concept of giving more samples. And we can also use other technologies like confocal laser, endomicroscopy, artificial intelligence, and even inventing new tools. So, for example, for confocal laser endomicroscopy, as you know, this is a laser fiber that is able to see actually at cellular levels using the fluorescence of the tissue, and we are able to see actually the cells and the tissue structure. So we have done a few cases with this technology using robotic bronchoscopy, confirming with a radial EBUS, and then introducing this laser fiber through the needle into the lesion and try to identify the areas of the lesion that we see malignant cells. So probably this can help trying to differentiate necrotic areas versus non-necrotic areas with viable tissue, and we can direct our tools directly to that to improve the diagnosis yield. Artificial intelligence in using pathology, this can help with the pathology miss, for example, that we have seen in a few samples that I have shown you. So in conclusion, and again, we can discuss this further during the question session, the diagnosis yield depends on the navigation yield, but also on the pathology yield. So remember, is the needle in the tool? First, you need to get the needle in the tool, but then the lesion has to be inside your needle. You need to have an adequate communication with a very good rows team and try to decide when there is enough evidence for you to put the highest amount of tissue into formalin and not keep doing slides and slides. And of course, this is an area for future development. I have shown you some of the newest technologies that we can use to improve our diagnostic yield. And we also have to think about possible new tools that can help us with this task. So with this, I will finish, and I will pass it on with Dr. Reisenauer.
Thanks so much. Great talk. So I'm going to talk a little bit about imaging in robotic bronchoscopy. I'll start with the 2D fluoroscopy, or what most of us might call the standard C-arm. This allows for a large field of view with RAO and LAO rotation, so you can have slightly oblique views. It's compatible with most fluoroscopy beds. It's minimal radiation dose, portable, easily accessible, and virtually self-taught. The problem with these systems is that it does not easily account for that divergence factor that Dr. Krishna spoke about in his talk. So here's a screenshot from the ion system, and you can see the optimal fluoro angle. And as long as you have a fluoro bed that doesn't have the metal railings on the sides, you can almost go 90 degrees totally lateral to the patient and get to any angle that you need to see to be able to biopsy any lesion. We also tend to use radial EBUS because although your C-arm can give you some data, and in this lesion you can kind of see a hint of something on fluoroscopy, many lesions are not fluoroscopically visible, particularly sub-centimeter lesions. And so that's where that dynamic confirmation is also important. This highlights here the divergence factors that we've talked about, because we are slightly off from the center of the nodule. And so being able to mark where you were in correlation with your radial EBUS, there's a feature called fluoral overlay that you can exactly identify where you got the best radial EBUS signal and mimic that with your needle or your forceps. These are all the adjuncts that you have to use to increase your diagnostic yield when you have standard 2D fluoroscopy to guarantee that in real time you are where you think you are. But again, the biggest drawback of 2D fluoro goes back to the CT to body divergence, and I won't spend a lot of time on this as we've already discussed it, but this really accounts for the differences in lung volume between CT and real time. And this has to do with multiple pre-procedural and intra-procedural and patient factors. It could be due to registration or just atelectasis from a prolonged procedure, the decrease in functional residual capacity when the patient lays supine on the operating room table and gets induced, multiple changes. So once we had some experience and gained some experience with the 2D, we then started experimenting in the cone beam room. We've done a lot of cases in the cone beam room pre-ion, but we tried to see if we can get the two to merge. And there's data out there about this already as well. As you saw, Dr. Krishna's data included all cone beam CT patients, but for those who don't have a ton of experience with cone beam CT, this affords you the ability to have fluoroscopy with real-time CT. You can then overlay augmented fluoroscopy to help guide your biopsies and have the ability to verify tool and lesion on 3D planar imaging, but also directly under fluoroscopy when you're biopsying a patient. And this can overcome that CT to body divergence. So here's an example of a lesion that we went after not so long ago. It's located deep in the costophrenic sulcus, and it was 6 millimeters in size, presumed metastatic lesion. This is with the ion docked on our cone beam spin with a PEEP of 20 and a 5-second CT spin. You can see the image quality is actually very good here, and you can still see the nodule on the cone beam images. So then I'm having the video here won't play. There we go. So as you can see here, you can now overlay your fluoroscopy, and you can see exactly where that 6 millimeter lesion is. And we actually used this for a localization case, and we were able to identify the dye and resect the lesion, and the patient did in fact have a metastatic papillary thyroid cancer. We'll go to the next slide here. So the augmented fluoroscopy is really nice because it minimizes the need to do multiple spins, which obviously anytime you spin, everybody has to leave the room, anesthesia has to do a breath hold. It can add time and it can add radiation. So having this fluoro overlay minimizes, theoretically the need to do the spin. We've done this a fair amount using bronchoscopic localization and then doing a subsequent thoracoscopic resection thereafter, and it seems to work really well. But again, the problems with and then I'll just mention that the effective dose for lung imaging, based on the currently available data that we have for the ARTIS-Z system, which is the Siemens system that we have in our institution, is actually relatively low, less than even a low-dose CT scan. So there's not a ton of concern for radiation. It's more has to do with the time and the efficiency and the consistent decrease or increase in atelectasis that you get with prolonged procedural times. But the disadvantages of this fixed system is, for many, the ability to get into that system on a reliable basis, and the cost associated with those expensive systems. So is there an in-between solution when everything else is portable? Well, this is the Siemens 2D fluoroscopy with mobile 3D imaging. I believe GE has one, and I think Philips has one as well. This is primarily a fluoroscopic modality with real-time 30-second portable CT imaging. This allows you to verify tool and lesion. It does not have that fluoro overlay that I mentioned with that augmented fluoroscopy, but it does in 30 seconds allow you to see exactly what your relationship is between the tool and the needle. It's portable, it's mobile, there's nothing special that you have to do for lung, and it can be shared with multiple specialties. As we have found in our institution, we're constantly fighting over who gets to use it that day because the orthopedic surgeons have tremendous use for this as well. So here's just a brief 30-second video of what the CO spin looks like. This is in our standard bronchoscopy suite, so there's nothing that needs to be sterile or special about it. You can do it as the robot is docked. And the images that you get, very much mimic a cone beam CT spin. If many of you have experience with cone beam CT imaging, the image quality is not perfect, but it is pretty good to see 6, 7, 8 millimeter nodules. This is just a case, it's a rather large nodule, but it shows that you can access a CT in 3 planes, because sometimes the reason why we miss is because we're looking at the axial screenshots alone and we think we're tool and lesion, but maybe we're slightly inferior to it or slightly anterior to it, and it allows you to visualize, again, that tool and lesion, particularly because as we get smaller and smaller with our biopsies, the likelihood for a benign diagnosis becomes much higher of a possibility. So it's getting the people that weren't in the procedural suite with you to trust your results that this is in fact a benign lesion. So a word on radiation, because this is a fluoroscopic modality, this is measured more in dose area product, so it's a slightly different unit of measurement as compared to a standard CT. So you can't compare this system to the amount of radiation you'd receive from a CT scan, because they're 2 totally different imaging modalities. This is a fluoroscopic modality. The fixed cone beam CT gives you a dose area product because it's a combined fluoroscopic and CT modality. And if you look at some of the data, for an average mean fluoroscopy time of 8.6 minutes, the previous published data show a dose area product of 64.5 gray per centimeter squared. And in our first 5 consecutive COS cases, our, believe it or not, mean fluoroscopy time was exactly the same, and our dose area product was only 35. So our evolution of experience with imaging systems, we first did our robotic bronchoscopy case as part of the first in human in the United States PRECISE study with the standard C-arm in May of 2019. Once we finished our 60 lesions as a part of that study, we then used a combination of either standard C-arm for fairly large lesions where we did not suspect divergence versus going to the cone beam room when we were doing single-stage surgery or going after really small sub-centimeter lesions or really deep lesions in the lower lobe. Since we have purchased the COS 3D system, if we're doing biopsies alone, we pretty much will do anything and everything with just this system alone because, again, it gives us the portability, which allows us to do it anytime, anywhere. And we really are only using our fixed cone beam systems if we're doing something a little bit outside of the box where we think that the value of that augmented fluoroscopy is critical to the diagnosis. So we have outgrown 2D fluoroscopy. I don't really know of a situation where we're using a standard serum anymore. And as I said before, for most routine biopsies, we use 3D mobile imaging, but there are special circumstances where we use fixed imaging. I want to stop there to give ample time for questions. Thank you, everyone, for joining the webinar. It's a pleasure to speak today and an honor and privilege to be joined by such wonderful panelists. We do have a question here that's popped up, and I'll just read it out loud, and then we can maybe have some discussion about it. The question is, what about lesions that don't have an air bronchus sign? When we do tunneling to get a concentric radial EBUS signal, is the vision important? I will say, and maybe we can just go down the row, I can't remember the last time I biopsied a nodule that had an air bronchus sign, to be honest with you. It's not even something that I look at anymore unless we're doing a study and I have to capture it for data. So it's essentially, it's a non-issue with the Flexision needle and the ability to tent to the airway and puncture the airway. I will, and then as far as trying to tunnel to get a concentric radial EBUS signal, sometimes when you start tunneling, all it takes, as Dr. Krishna mentioned, is one drop of blood or one little speck of saline to get in front of your vision, and then you no longer have vision. So, all of these things should be done with care and with caution, obviously, because you don't want to tunnel into something inadvertent. But let's say you did tunnel into something inadvertent, I'm not sure that the vision really helps you at that point. You've kind of done the damage. But I'll hand it over maybe to Dr. Bussy and then Dr. Krishna to comment.
Okay, thank you. So I would like to add to that sometimes when we, indeed, I agree with Dr. Reisenauer that we don't really look at the bronchus airway sign much anymore with this type of system. And sometimes when we go into the lesion through the airway wall with the needle, so at the beginning, we may not get in any radial EBUS sign, or we may get an eccentric radial EBUS sign. And then after a few passes with the needle, then, we are constantly checking with the radial EBUS sign if we're not getting the diagnosis. And sometimes an eccentric view or a non-view changes for a concentric radial EBUS view, because we went, of course, with the needle through the airway wall into the lesion. And if we're not getting enough samples with the needle and it's still non-diagnostic, then that's a good time to use a forceps when you get that concentric radial EBUS sign through the procedure.
Dr. Krishna, your thoughts?
Yeah, I agree with both of you as to what you said. I would just add that, when you tunnel and pass a radial probe through to look at a lesion, even if you get a concentric lesion, there is no guarantee that when you go back with the biopsy tool, you're going to go through the same hole. And obviously, drop of blood can obscure your view, and you may not be able to pass it through in the same direction. So it may be a concentric view when you pass a radial probe EBUS, but you may not really achieve the same trajectory with the biopsy tool.
So I'll throw a question out there to both of you. We're going to be entering an era now, and you both might have seen it as you start reviewing for some of these meetings and abstracts and things that start coming through. When an abstract or when a person comes to you and says, what about this study or what about that study, what are the key data points that you're looking at? Because certainly when somebody comes to you and says, oh, well, Dr. Smith has a 96% yield, but Dr. Jones had a 77% yield or a 92% yield, is that the number that really matters? What are the numbers that matter?
Well, I'll take that first. It's an interesting question. I mean, as a surgeon, you know all too well that there is an operator factor. So there is not going to be a uniform diagnostic accuracy. This is not giving Spiriva to a COPD patient and expect the same result. Maybe that's not a good analogy, but there's going to be operator variability. And again, we all know that the diagnostic entities of various nodules, be it a fungal infection, malignancy, or other benign diagnosis, is highly dependent on the geography. So it also depends on what we consider that as diagnostic yield. And again, as Sebastian accurately pointed out, that we sometimes know that the needle is in the nodule, but it's the nodule in the needle. That's the difference between accuracy and diagnostic yield. And there are many other factors that play a role there. It's the local pathology factors, the fragility of the cells. If you apply excessive shear force in pumping out the cells from the needle, they may lyse off, and all you see is blood, and you have definitive confirmation that the needle is in the nodule, but the nodule is not in the needle. So there are many other factors that play a role. So I don't think there is a number that is something that would be appealing to me as to adapting a system. It's the overall experience and building a program. You learn to work with certain pathologists. You learn to work with a certain system, and how is that serving your own patients compared to what it was before will be the most important factor for me to adopt the system.
Yeah, I agree with Dr. Krishna, and also, of course, you need to compare always the nodule size, the location. This is another discussion that we can put out there. Is it a solid nodule, or is this a good system also to diagnose ground glass nodules? That's also an interesting topic, since we do use radial EBUS to try to confirm the nodule location, but and that ground glass nodules are hard to see during radial EBUS. They're not impossible, but they're hard to see. So is this technology good enough for ground glass nodule, and what size of ground glass nodules, and so on. So yeah, I think that you just need to compare, apples to apples, and then you can get your conclusion. But it's also very operator dependent.
I'll throw one more out there in the last 2 minutes that we have, and I'm being a little bit cheeky by asking this question, being a surgeon as well. But the diagnostic yields, as you look through the early data that has come out, ranges anywhere for all robotic platforms, somewhere between, the high 70s to the low 90s. This is in comparison to the current algorithms that are established that say if the pretest probability of a pulmonary nodule is greater than 80%, you do not need a biopsy and you can go straight to surgery. Do we need to hit a specific, reliable diagnostic yield to change that paradigm to where all patients biopsy prior to surgery? And Sebastian's laughing exactly why. I know exactly why he's laughing, because he knows how I feel about this. But I'd love to know how both of you feel about this.
Right. Well, remember that by doing this robotic approach first, you also do mediastinal staging at the same time. So I think that's a huge advantage of going through the airway and be able to do diagnosis and staging at the same time versus doing CT guided, and of course going directly to surgery. But yeah, if you have a nodule less than 30 millimeters, peripheral nodule, PET positive, negative mediastinum, why should you do this? Well, you should ask your patient, do you want to know what it is before going through surgery, or you just want to just go through directly to surgery? And they have the right to make their decision as well.
I agree. I think we're a minute over time. Dr. Krishna, I'll give you the closing comments, and then we can thank everybody for joining.
Sure. Yeah. Thank you for that. And yeah, pretest probabilities were probably based on the test that was done, which is surgery. And perhaps if we are able to biopsy a lot of these nodules, and we may be able to get alternate diagnosis, then that pretest probability might change, the test being a minimally invasive procedure. So that remains to be proven. And also we know based on LCAP data that more than 90% of nodules that we see are not malignant, so they don't really have to go to surgery for diagnosis. And again, as an interventional pulmonologist, and I'm aware that you are too, that we actually like to prove that something is worth going for surgery, and we are not in favor of sending a patient for a surgical intervention just for diagnosis. If it's a curative intent, that's great. They have to go to surgery, but if it's just for diagnosis, we are reluctant.
Okay, I think we're a couple of minutes over time. I just want to thank everybody once again for joining. Hopefully, we sparked some discussion and some contemplation. And on that note, we'll sign off. Happy Wednesday.
Thank you, everyone.
Thank you. Thank you. Bye-bye.
Thank you, Dr. Reisenauer, Dr. Krishna, and Dr. Bussy. And thank you to everyone for attending today's ATS Industry Innovations webinar. If you have any additional questions, please feel free to contact the presenters at their respective institutions. This webinar will be archived and posted to the ATS YouTube channel in about 2 weeks. On behalf of Intuitive and our presenters, thank you for joining us today, and have a great rest of your day.